Thanks, everybody. So I apologize in advance. I have toddlers, and they keep getting me sick, so I'm getting over a cold. I don't have one right now, but I have a little bit of a lingering post-viral cough, so I'll need this quite frequently. So I just want to talk a little bit about something called Duffy null phenotype that I'll explain quite a bit about what it is in this talk and why it relates to clinical trial participation throughout the next 15 minutes. So here are my disclosures. So I thought that instead of just telling you right off the bat what Duffy null is, we can kind of think about a short journey of the intertwined history of clinical trial eligibility criteria, dose modifications, and Duffy null phenotype. And to start off, we have known essentially since the Nuremberg Code and then the Declaration of Helsinki and the Belmont Report that clinical trial eligibility criteria are necessary to really select the patient population of interest and to make sure that we are minimizing foreseeable and avoidable risks to people who are participating. But as early as it seems like 1996 was the earliest article that I could find where people were thinking about, well, what's the downside of having eligibility criteria that are potentially too restrictive? And this was Stephen George, who's a biostatistician at Duke, who was thinking about this and saying, well, if we're too restrictive, we limit generalizability, failure to mimic clinical practice. We have issues with complexity, costs, lack of accrual, and then I've added some on the bottom in terms of decreased patient trust, depending on who is not enrolled, and as well as biases to correlative studies, biobanks, and future drug development. And around the same time, we had the description of what was then eventually termed a poor moniker of benign ethnic neutropenia, which was the understanding that different populations within the United States had different levels of white blood cell counts, and this was largely due to differences in neutrophil counts. And they didn't really understand the biologic mechanism for this, and so they kind of gave it this moniker because it was benign. It didn't really lead to any pathology, any increase in infections, any differences in immune response. And so this is kind of where this picture begins to take place. And as a result of this, several in the cancer care community started to look at how this lower neutrophil count ends up impacting cancer care. And so Dawn Hirschman did some of the early studies looking at this. On the left, you can see the title of a brief communication she had where she was basically showing that this benign ethnic neutropenia potentially was associated with treatment delays for African American women undergoing chemotherapy for early stage breast cancer. And at the same time, we also saw that the NCI was getting interested in this, and again, kind of the early to late 2000s, looking at, well, if this is the case, should we actually be changing our neutrophil cutoffs for African Americans in terms of their initiation or resumption of chemotherapy? And we know all of this because we think about adverse events in clinical trials, and we say that, okay, we have CTCAE criteria started back in the early 1980s to really say what's normal in terms of people's response to chemotherapy, what's potentially risky pathology that's coming up in terms of neutropenia, in terms of other things. And the CTCAE criteria were based on US, UK, Japan, a couple of other European countries. And so at the same time, the criteria for CTCAE were largely based on male and Caucasian or Asian individuals. And so those norms around what's normal, what's abnormal in terms of blood counts, in terms of neutrophil counts, was not based on African Americans. And then we kind of had a better reason as to why potentially quote-unquote benign ethnic neutropenia existed, and it is the Duffy null phenotype. So what is Duffy null phenotype? It is essentially this T to G substitution that you see in the top right of this Duffy antigen receptor for chemokine genes, or DARC. You'll see on the bottom left, it's also called ACKR1. So you'll see that kind of pop up a couple times. But essentially, it's this minor blood group antigen. And what that means is you have like your ABO blood groups. You also have a Duffy blood group. And on the bottom right with this erythrocyte, that's a red blood cell. For those of you who are not clinical, when you have Duffy null, you end up basically not having this little Duffy antigen on the surface of your red blood cell. Now, why would that actually happen? It's a blood group that everybody on the planet has, but some people just don't have this particular antigen, and it's because Plasmodium vivax, or P. vivax you see there, is malaria. And so people who live in malaria endemic countries basically have selected away from having this Duffy on the surface of the red blood cell, so malaria can't get in. And so you have kind of this very biologic reason for having this particular Duffy null phenotype. And I know on here I'm talking about red blood cells, but consequently, Duffy null phenotype actually has some differences in terms of the interactions between blood cells. And so, long story short, people with Duffy null phenotype not only have this difference on the red blood cells, but they end up having a difference in where their neutrophils like to be located in their body. So when we get a tube of blood from somebody, we just get the neutrophils that are in their actual bloodstream at that time. But neutrophils are in every tissue in our body, and people with Duffy null, instead of being in the bloodstream as much as people with non-Duffy null, they end up being a little bit more in the spleen. So we just can't see them. Same amount, but you just have a different location for the neutrophils, and that's why there's no difference in infection or anything else. But it looks like they have lower neutrophils. And so you can see here, where is Duffy null located in terms of the population? The super dark red means almost everybody in that area is Duffy null. There's Duffy null across the world, so everything's at least a little bit pink, but is really high in West and Central Africa, as well as the Arabian Peninsula and some of the coastal areas of South America. But in the US, 66% of all African Americans, self-identified African Americans, are Duffy null. Less than 1% of self-identified non-Hispanic Caucasians. And this leads to the neutrophil reference ranges that you see here. So in these countries, we have lower limits for neutrophil counts that are anywhere from 500 to about 1,040, versus in the United States, we have, in Boston at least, this is the reference range in gray, which is the lower limit is 1,950 for Brigham and Women's Hospital. And when you actually take a group of Black Americans and you Duffy type them, you see that in the red, the people who are Duffy non-null, which again, very similar to Caucasian populations in terms of their neutrophil counts in the red there, they're right smack dab in the middle of the reference range. But people with Duffy null in the blue, about 25% of them just sit normally below the lower limit of normal, and so they're thought of as having quote-unquote low neutrophil counts, but it's just because their reference ranges are wrong. Again, normal variant, no issues in terms of response to stress, infection, GCSF, no risk of infection, normal bone marrow pathology has been shown a number of times. So why does this matter for clinical trials? One is the eligibility criteria. So this was a study that a couple mentees and I did last year, looking at basically big phase 3 clinical trials in the US and UK, very recent breast, colorectal, lung, melanoma, prostate. It basically said, how often do you have an exclusion criteria for your trials that has the neutrophil count in the normal range for people who are Duffy null? And in the blue, you have exclusions that are explicit, meaning you have a specific cutoff that is within that reference range. Yellow is things like you need to have normal bone marrow function, or you need to have adequate laboratory values. So kind of implicit exclusions. And the second to bottom and the bottom lines basically are the total sum, different ways of actually calculating that. But anywhere from 70 to 75% of our current phase 3 clinical trials are excluding some proportion of people with Duffy null for having a normal ANC for them. And we're now applying some of this to a real-world cohort of patients. We, in most of these real-world cohorts, do not have actual Duffy status. So this is basically saying we know that 2/3 of African Americans are Duffy null from a US cohort. We know that less than 1% of non-Hispanic white patients are Duffy null. And so if we look at a number of common regimens that were used in NCCN for these same 5 cancers, and we look at essentially the cutoffs for neutrophil counts that they use in those the studies that kind of led to those being in the NCCN. The cutoffs were 1,000, 1,500, and 2,000. You can see essentially in this graph, as you're moving from 0 on the left in terms of a cutoff for neutrophils up to 2.2, I think, is on the right. I know it's a little bit hard to see, but essentially the line with the big green star at the top is how the proportion of African Americans that are excluded for any neutrophil count, and then the lower one is the non-Hispanic white count. And so you can see as you're moving to the right, after about 1.5 or 1,500 in terms of this ANC cutoff in the table here, you end up having about 2% of people excluded, and then by an ANC cutoff of 2,000, which was also used in some trials, almost 10%, so 8.8 of non-Hispanic Black patients excluded. Now again, this is just by race and ethnicity, so this is kind of the downstream effect, I would say, on race ethnicity of Duffy null. And so we said, well, from some of our early studies, we actually identified Duffy status. We didn't have it in that particular cohort, but we created a prediction model, which is essentially, I don't know if I have a pointer anywhere, but essentially top right of what you're looking at, there's a little graph curve that's just basically saying that we developed a prediction model that works pretty well to infer Duffy status amongst Black patients. And so on the left 4 bars here, you're basically seeing what are those neutrophil counts for this real world cohort of essentially patients with cancer coming in to get systemic anti-cancer therapy, and non-Hispanic white, Hispanic other, and non-Hispanic Black are kind of the categories. And so we actually broke down the non-Hispanic Black patients with those arrows into the Duffy non-null population and the Duffy null population. And you can see that essentially, I don't know if I have this, good. The median neutrophil count for patients who are non-Hispanic white is pretty much the same as the median neutrophil count for patients who are African-American patients who are Duffy non-null, but the median for people who are Duffy null all the way on the right is, of course, much lower. And our ANC cutoff of 1,500, which is most commonly used, would essentially lead to about a third of these patients being excluded from clinical trials. We're also starting to work, I see Chris actually right in front of me, we're also starting to work with the Leo and Mur cohorts to essentially do the same analysis where they actually have whole exome sequencing for all of their patients. They've already looked at this across race and ethnicity to say that yes, there is an impact of neutrophil count on exclusion criteria for diffuse large B-cell clinical trials as well. And now we're kind of going to be looking at that specifically for Duffy status, which we assume is the big driver of why this is happening. Now, not only getting into trials, but when you're on trials and actually then when you get standard of care chemotherapy, Duffy status also seems to be making a big issue. And this is that in that same study I showed you before, we didn't only look at eligibility criteria. We said, well, let's look at the NCCN and say what were the trials recommended dose modifications for ANC. So how often do you need to lower your chemotherapy dose for neutrophil counts that were, again, in the normal range for people with Duffy null phenotype. And we saw less, but still pretty substantial. About 50% of all trials basically said if your neutrophil count is quote-unquote low, again, normal for people with Duffy null phenotype, you should lower, delay, reduce your chemotherapy. And that's important because a reduced dose intensity of your chemotherapy, any less than about 85%, means inferior survival. So you're potentially just underdosing these people. This is largely because of the CTCAE criteria as they are, where you essentially have grade 3 and 4 criteria, or excuse me, grade 1 and 2 criteria saying that at baseline, people with Duffy null have a grade 1 or grade 2 criteria, very likely then to have a grade 3 or grade 4 criteria after they're on treatment, and you're essentially kind of handicapping those people from the beginning. And you also have issues with disease and response definitions, most notably, at least in the blood cancers in CLL, where you have a neutrophil count for complete remission. That includes neutrophil count in the normal range for people with Duffy null. And so what are we doing with all of this? Again, we had a nice little piece in New England Journal a couple months ago that kind of outlining all of these things. And we're trying to do quite a bit. Some of it's infrastructure, so how do we change the CTCAE? How do we kind of work with large groups to essentially include Duffy status testing into their clinical trials? I'm happy to talk with anybody in the industry about that because we have a number of partners that we're working with, and the more the better. I think the big thing is that we have so many drugs that are already approved for which we don't really know the right dose modifications for people with Duffy null. And so I'm leading a multi-center trial right now looking in multiple myeloma and looking in breast cancer to say for the common regimens we use for those diseases, what happens if we use lower dose modification cutoffs for people with Duffy null? Is it safe? Is it effective in terms of increasing how much therapy they get? And then from the standpoint of remission criteria, working with the different groups there to kind of revise them. So I think the take-homes are, one, talk to your local folks about if Duffy status testing is available, which I should mention it is. It's a very common blood test because it's used in blood typing. So it's like 10 to 30 bucks a test. Every blood bank in the country does it. It's very easy. It's just not often reported in Epic or your medical record system. So essentially, we need to think about implementing Duffy testing quite widely, and then thinking about, for patients who have Duffy status, how we actually need to change our eligibility criteria, how we need to change our dose modifications and those things to make sure that we're treating them the same as everybody else. So just want to say thank you for your time. Oops, I should go back one. Lauren Mers on the bottom left is the fellow that's led quite a number of these things. So unfortunately, she's going to Michigan in a couple months now that she's finishing up her fellowship. But her and then Stephen Hibbs towards the bottom right, I've been working with over the last 3 or 4 years on this. So a lot of the credit goes to them. Thank you very much.